practice call. So if you haven't joined us before, this is a virtual just platform that we're trying to do like every other month or so to bring together primary care PTs to present, to ask questions, and really just like move our practice forward as primary care physical therapists. So my name's Lena. I'm the practice chair for the SIG. We have Evan on here too, who's one of our chairs. And tonight we have Micah Wong with us. If you saw any of our social media posts, he works at Samaritan in Oregon as a primary care physical therapist. And I'm going to let him introduce himself and get us started.
I see that there's another Micah in here too. I got confused because I was like, did my phone join in randomly too? So perfect. Well, aloha everyone. My name is Michael Wong. I'm originally from Oahu, Hawaii, and I've been living in Oregon for the last 10 years. And I'm in my fourth year of clinical practice. I work at Samaritan Health Systems, and we are a kind of like small hospital system in the Mid Valley region of Oregon. And it's funny because I say small hospital system, knowing that some people work in extremely rural communities. So I'm pretty blessed. It's a critical access hospital. Let me jump into sharing my screen and I will kick things off here. Okay. And can everyone see my screen? Everyone see what's happening here? Cool. Okay. There we go. So today I wanted to talk to you guys a little bit about the idea of primary management, primary care mindsets in the outpatient context. A year and a half ago, at the first primary care summit that was held over in Waco, Texas, I got to present a bit of a background on our primary care system setup, where we were embedded in a family medicine clinic that was in the parking lot of our critical access hospital. So it was still technically considered on hospital property and was a rural health clinic. For the past year, that program has unfortunately been shut down. So I was able to share some of the insights that we had gained from our embedded primary care model being taken out, basically. The cool thing is that, well, I say cool, it drove me a little bit insane, is that for my first 2 years of practice, I was mostly embedded in family medicine. And so I didn't get the full outpatient experience of seeing this whole wide breadth of patients, getting to build relationships with them for months and months and months at a time. My first toe dip into physical therapy was in family medicine and was as a primary care physical therapist. So it was actually a big shock to my system when suddenly this program got taken away and I was just put back in outpatient full time. I had a lot of panic, a lot of figuring out what do I do with my life? Should I just go move over to New Hampshire and go work with Evan in the VA? I don't know. A lot of those. And I started kind of feeling more and more that no, there are things that I can take from my experience and my learning here that I can apply here. And I think that we as physical therapists can encourage more of in the students that we mentor and in our colleagues. I'm willing to bet that I'm preaching to the crowd with those of you who are here. So maybe if you can see this, it's a little bit more of just my journey in understanding a primary care mindset in outpatient physical therapy as well. When we take a look at those seeking care, it's divided, and our roles are different when we're in primary care versus something like secondary care in classic outpatient. When a patient first sees themselves kind of needing help, needing care, they start care seeking. Their first point of contact is usually just to call up their primary care clinic. It's what's available, it's access, it's what's traditionally been done. From that model, they then get routed to a primary care visit. And in our embedded clinic, there was actually a second option available to them, and that was to also see a physical therapist either before or during the same time as their primary care visit. That's primary care, right? Someone comes in, they have no idea what's going on. They just need someone to take a look at them. That usually gets handled by a PCP, primary care, and then that can get diverted to secondary care or tertiary care. And that's where I currently now sit, right? I'm PTAP, PT eval and treat is my bread and butter on those referrals. Or it could also involve specialty referrals there too. So, what did it look like in that model previously? Well, the patient would come into their family medicine primary care visit. They'd get roomed, they'd see their PCP, and then there would be a warm handoff to a physical therapist at the time of their initial visit. This was usually done by the MA's rooming. They'd take vitals. The PCP would take a look at comorbidities. They'd ask about medication management and perform a little bit of an initial discussion and assessment. But by the time we were done, the PCP visit ended up turning into 3 minutes of the provider saying hi and then being like, the PT will tell us what to do. So here, go talk with them. So at that time, then we were responsible for musculoskeletal, vestibular, and neurologic patients who were coming in. If the PCP felt like, okay, this is something the PT can handle, I can actually just go escape to my room to go write some notes here. We would use a host of different global measures, PROMIS and the Keel MSK tool. And a lot of times it would turn into discussions on diagnosis, workup, self management strategies, and prescribing a home exercise plan there too. What I really appreciated about it is that everyone, of course, being embedded was in the same building, right? We're all in the clinic there together. So I could actually talk with care coordinators and behavioral health just in the office right next door. And then I could turn around and go conference with the PCP who was right there too. And I could make recommendations on imaging, medications, specialty referrals, referrals to PT. Very collaborative and very, very fun. However, that got shut down. And then I was put back in outpatient physical therapy. And all I knew was collaboration, and all I knew was being embedded, and all I knew was being able to talk with all of these physicians and residents at the same time. Um, so the tale of two pathways that we see here in primary care, this is what it felt like. I felt like I just saw everybody. I saw everybody who came through the door. I saw so many undifferentiated cases of just weird, random things that people would experience and they would come to see their primary care doctor for. And oftentimes the primary care doctor wouldn't know, and they'd be like, well, I need a second set of eyes on this. So let me just bring in the PT for things that we probably weren't even qualified to see, but they just needed a second set of eyes. So they would call us in. Normally, our days were split up into two 4 hour segments. So in 4 hours, I would be seeing anywhere from no patients, if it was a light caseload day, to 13 patients in a 4 hour period. There was a ton of face to face collaboration, and that was really fun. In our outpatient system that I'm at, like many hospital systems, Samaritan actually does not have direct access. And so I only see patients now that have been differentiated, that have been screened, and that have referrals coming in. All these referrals are generated from primary care and specialty care clinics. And I am in a rehab clinic. So I'm with other PTs, I'm with OTs, speech therapists. We do have a massive queue. So we are in a rural area. We have 1,600 patients in our work queue right now across 3 different clinics, and we are struggling to find PTs to work. We have 7 open positions if anyone wants to move to Oregon. Come on down. So the need is there, and it's just a very different setting than what I was used to. Then the next question comes to, we have these differences in settings. Does there need to be a difference? What are the focuses? What are the goals between the two of these? As I was trying to think through it, I kept on, when I first was put back in outpatient care, I was getting so frustrated because I would get these patients who should have been differentiated, that should have been diagnosed, that should have had workup done. And I was kind of seeing, oh, like, you obviously actually should not be here in physical therapy. Like, we should send you directly to orthopedics, or you don't need me. You need to go see your cardiologist and follow up there. Like, this is kind of wild here. But the mindset is very different when you are in these cases, because I would be an outpatient. Sometimes I would try to bring my concerns up to the referring docs, to my colleagues, my coworkers, and I would kind of get this like hand wave of they're there in PT, keep working with them in PT, kind of hold them here for a little bit. PT sometimes can feel like it's yeah, just keep them out of our office for 6 to 8 weeks until they need to come back, like a kind of holding cell. So two different ideas in primary care. It felt like, okay, diagnosis and patient direction were paramount. What was this patient to do next? Could they just enjoy life on their own? Could they self-manage? Is this something that we could trust to natural history? Educating was still huge. Referral plans are still huge. In tertiary care outpatient, very much more functional deficits, right? Treat the impairments, a lot of goal setting. Patient education and prognosis still mainstays in that, but it felt more about patient capture in a way rather than patient direction that I noticed. I think we are all pretty familiar with this paper now. The primary care SIG came up with a position statement white paper that you all can find, and I just took this from the definition statement. Primary care physical therapy was defined as providing comprehensive wellness, triage, diagnostic, and management services within primary care pathways for individuals with physical and functional needs. So that idea of being within the pathway, I think really does set up PTs. As an outpatient physical therapist, I'm not seeing people at primary. I'm seeing them in tertiary care, but I still think there's a lot of mindset and still a lot of value to be gained from thinking from a primary care perspective in tertiary care outside of a primary care pathway too. So integrating the silos, as I was stuck out in outpatient care, um, I kept running into these same problems and mindsets and things coming up over and over again. So I want to share some of those as well as some of the solutions that I feel like I've come to in the last year and a half of being outpatient full time. The lone wolf, biomechanical focuses of treatments, a focus on PT interventions alone, and a self limiting scope of practice. The lone wolf idea being I take a patient, my job is to hold them and never release them. My job is it's me, ride or die. This patient is going to get better with me and I'm never going to release them back because it means that I failed the patient if I release them back to their PCP. And everyone's going to be like, oh, I should never send them to this physical therapist again because they didn't heal them. A biomechanical focus, talking about upslips, talking about leg length discrepancies, talking about agonist antagonist muscle groups, trying to give these reasons for why someone has been in chronic pain for 20 years. Another issue, the PT intervention focus. When all you're around are PTs or other rehab clinicians, you're kind of an echo chamber. You only know what you know. And if everyone around only knows basically from, if we're drawing from the same pool of knowledge, we lack these areas to kind of shoot off for some creative thinking, creative problem solving. And then finally, the self-limiting scope. All of us are in this SIG for a reason because we want to be around like-minded people who are willing to kind of push boundaries and realize that physical therapy is more to offer others too. The biggest barriers to physical therapists are other physical therapists. We get afraid. We get afraid of liability. We try to follow every single line item that's ever been created without asking why or thinking, is this something that we could push for change in? So in the last year and a half, these are kind of the things that I did to try to fight these instincts or to fight these things that were building in me as I was working for the last year and a half. Instead of being the lone wolf, I would really try to educate patients that I was a member of their collaborative care team, that they're not just on physical therapy island being forced to be here for 6 weeks until they can get their MRI, that, yeah, I'll talk to your doctor. I'll send the messages. I'll talk to your surgeon about things too. That we're a collaborative network here. You're not just stuck with me like this. Epic introduced the Epic chat feature, which I found has been really nice too. So instead of just sending my plan of cares to referral sources, now I can just send a simple 1 or 2 sentence update every couple of weeks. And I noticed the sports medicine docs really love that collaboration, just to kind of let them know what I'm seeing, ask them their opinions on it too. Some of them, I mean, people are pretty busy. I'm pretty busy. I have a hard time responding to messages too. But from the docs that I've been able to talk to, they really like how quick and easy it is to collaborate. The biomechanical focus on issues. I don't take these referrals for face value, and I think all of us are at a point there too. a very involved workup that I feel like has been trained into me from working in family medicine with undifferentiated patients. And so I find that I go pretty deep into evaluations to take a look at old lab values, old imaging, their specialty notes and specialty referrals that they have been worked up for to considering the Vindicate differentials. This is part of the orthopedic residency program. Vindicate is an acronym that vascular, iatrogenic, just different ideas of what could be causing this outside of a musculoskeletal lens here too. And then holding on to my training in biopsychosocial care, that all conditions have a biopsychosocial involvement, not just the ones that we think are super potentorial or at people's heads, but that it affects everything in the way we do. And so I still keep up with social determinants of health collaborations too. I reach out to a ton of care coordinators. I am pretty well aware of what social services we have to offer too. And I feel like that is really valuable for me and has a lot of cool patient buy-in when I tell them if a patient is homeless and that's the biggest thing on their mind, like, yeah, let me get you a gym membership that is paid for through your insurance so that you have a place to shower in the mornings and you can be at the gym to work towards some of your physical activity goals that we need here as well. And I'm going to shoot ahead a message to the care coordinators to let them know that you're going to call. And here's their number too. PT intervention focus. I do a lot of time prognosticating and educating patients on alternative treatment strategies on, hey, what else besides physical therapy might be helpful for you? And it's nice because it takes a lot of the pressure out of it as well. I'm not a surgeon. I didn't go through 9 years of med school and residency, but I think in my experience and within my scope, I can educate patients on the different pathways that are available to them, as well as the evidence on prognosis for some of those things too. Self-limiting scope. I not afraid to diagnose. Oregon is a weird state where we don't have a lot of definitive language around diagnostics, and we don't have a lot of definitive language around imaging as well. And so something that I have been finding helpful is I won't be afraid to put a name on something that a patient presents with or disagree with the referral sources too. So I'll discuss that with PCPs or with referrals as well. And advocating for imaging or some medication usage too. A lot of that, thankfully, has just been trained with working with the family medicine doctors too, and a lot of the residents for the first 2 years. And then diagnostic ultrasound has been very interesting to me and been using that for the last 3 years and getting really serious. I just bought a Clarius probe and it's been wonderful. I used it for the first time today. I've been training all weekend with it. I was stealing the probe from the CC, and I'm not stealing, but sharing the probe with the critical care unit because they really only used it for bladder scans. And the probe broke, and I can't go without it anymore. I rely on on ultrasound now. So I was like, all right, I'll buy my own, and I love it. So these are things that I use to kind of keep myself sane as I saw, okay, here are some of the problems that I commonly see in outpatient. And here are some things that I've done to make me feel better about the way that I practice in this environment. So let's go to what it looks like. I have a few patient cases here. And again, my goal isn't to get too nitty gritty with these patient cases. It's more to just show, hey, how did some of my mindset things affect the choices that I made in managing these patients too? I'm definitely not uber prepared as a case study here, but let's go through it. Okay. So, first patient, DJ, a 71-year-old male, he came in with a year of anterior shoulder pain that made it hard for him to work and to sleep. He was a gas attendant in Oregon. I don't know if you guys know this, but just until recently, you weren't allowed to pump your own gas. And so it's a thriving industry to pump gas. I did it for 3 years at Costco and it paid my way through PT school partially. But he had pain every time that he would go to take the gas nozzles out and then put it back in. And it was messing with his sleep. You can see his past medical history there. He's the main caregiver for his wife. And he came to us because he was really nervous that as she was getting weaker and weaker, he wouldn't be able to take care of her. And that was kind of the overarching thought and fear. And that was his driving need for intervention. So he was advised by his primary care physician to take over the counter ibuprofen. And so he said, okay, I'll do that. He's took 3,000 milligrams daily for 4 months. And then I ask him, oh, that's so interesting. Okay, hey, do you have any stomach pains? And he goes, yeah, the stomach pains and not eating are worse than my shoulder. He said he's living off of Tums to try to survive. And he was not happy to be in PT because actually he had been in the week before and he walked out of that evaluation because the therapist had a hard time finding his MRI report. And as the quote you can see there, you can see, what's the point of therapy if you don't even know what's going on? So he just, whoop, he stormed out. So he's seeing us and I'm thinking, oh, what do we do here? What's going on? 0 to 10 pain at rest. How wild is that? Crazy, 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 crazy. Internal rotation resisted strength test. His internal rotation strength was greater than his external rotation strength. This is a quick and dirty screener I use just for intra-articular versus extra-articular cause of shoulder pain. So at this point, I'm thinking, okay, rotator cuff related shoulder pain. I don't need to get fancy with it there too. 118 degrees of abduction at the start of the evaluation. We just start gently moving through things, and suddenly he starts raising up to 155 degrees. Grip strength is very much within norms. There is a little bit of a kilogram difference between sides. He is right hand dominant, so I should expect that to be higher than it is too. And then tender to palpation, exactly where you would expect for anterior shoulder pain with a quick dash of 61 out of 100. So someone with zero pain whose range of motion is quickly able to improve, who has a quick dash of 61 out of 100, which is moderate disability too. And so from this, I started thinking, okay, what do we do? How do we approach this? So what's the traditional PT intervention? We addressed his range of motion and strength findings. We managed it with a home exercise program. A big part of it too was discussing his beliefs on what do you think's going on? Do you think that the more you move it is gonna make it worse? I was able to see his MRI report. He had pretty bad tendinopathy, long head of biceps, and supraspinatus tendinopathy, but no large tears. It's what you would expect for someone in their 70s who has just lived life there too. And then we worked together to set goals on sleep and improve symptom management with work. So if I had a student, I would say, okay, that's the perfect spot to be at. That's pretty good right there. The primary care patient management side of me, though, this is a line I'm going to be repeating: taking ownership of the patient's goals and conditions within my scope. So, what things do I have control in? What things do I not have control in? And do I know someone who does have control of these that I can advocate for to help the patient there? So, immediately, his stomach pain and not eating and his inability to eat living off of Tums is a huge red flag, right? And so I take a look and I review his past medical history. So he does have a history of gastric ulcers and was just told to take over the counter ibuprofen. So I called up his PCP, and of course I get the reception desk, not anyone clinical, and I just say like, hey, I have a patient here who has like severe stomach pains with over the counters. Um, he still notes that he is having pain at night with sleep. I'm wondering if you would consider Celebrex with or without a PPI cover. And the receptionist is like, okay, that's fine. The diagnostic, and then I did diagnostic ultrasound because he was really concerned that we wouldn't have an idea of what's going on. And I just talked him through movement. We went through repeated shoulder abductions so that he could visualize it and that he would be less fearful of moving. And I talked to him about how his work activities wouldn't be physically harmful for him to do. In fact, it probably could be helpful. And then we went through the long list of options available to him. We talked about conservative care with us. I talked to him about injections. I talked to him about arthroscopy, where they might want to do some tenodesis because of his long head of biceps injury there too. And he was going, I do not want surgery. I do not like needles. And so I told him it looks like you're in the right place then to be working with us. This is another diagram I think we're all familiar with. This is from the IFOMP cervical red flags paper that was published, I believe, back in 2020. And I think it's great to see this continuum that we all operate in, from no concerning features, let's keep going, to, hey, you shouldn't even see me, right? Like you need to be referred, get out of here, don't come back until this thing gets settled. But I would also say that that middle area here with a few concerning features and some concerning features is very much dependent on what resources you have available to you, how collaborative you are, and your risk tolerance due to your skill set and training too. Um, so with a patient like this, uh, I know I was thinking and trying to reflect on it too. Is this a patient that would have just been referred back to their PCP for this? You know, it would have been a case of like, oh, I don't know what to do. Go call your PCP. And then they take 3 weeks to go get in with their PCP for a visit. And then 3 weeks later, he's been taking 3,000 milligrams of ibuprofen daily and not eating like for that time. Or is it something where I could just make a phone call and make a recommendation? And that order ended up getting placed the next day too. So that I think we can operate in these continuums depending on our training, and I think through safe patient management and upskilling, we can try to capture a little bit more of that orange and red zone and be keeping an eye on these patients and being actually helpful to them, not just keeping them in the physical therapy clinic. Because really, what is physical therapy? Is it just exercise? Is it just modalities? I don't think so. I don't think there's really anything too unique to what we do. I think we're trying to bring evidence-based musculoskeletal management to people. I think we're trying to bring lifestyle interventions to people, and we're just trying to be evidence-based clinicians working with patients. And we're really good at using our hands at the same time. I kind of think that's a big piece of it too. Standard models fail to consider patient management because we have to be doing and doing and doing. And I felt like I saw that so much in outpatient where I would be seeing patients and I'm like, I only need to see you for 20 minutes. Like really, what am I going to do for 25 minutes with you? We're just going to talk and I'll move your shoulder a little bit. Um, but it doesn't take into account calling up a PCP and making a recommendation that changes the entire course of his care. PT is not something I do to people. I think physical therapy it's a profession and it's who I am, and I've been having a lot of fun kind of living in that in the last year and a half. And I think you can all have fun laughing at this because this is how I think most patients come in and think that it's going to be like. So this patient DJ, he ended up coming back a week later saying that he was able to eat everything he could. And he found that his stomach was actually worse than his shoulder at night. And so he could actually sleep again. He was a little sore with end range flexion with overpressure. Um, and we just kept him moving. He said he wasn't fearful. He had to start doing transfers with his wife, so we practiced some ground transfers. We practiced some stand pivot transfers with him, and then he came back 2 weeks later and was like, "Look at me, I'm good." And I'm like, "Get out of here! I'm gonna discharge you." Um, so you know, cool case. I think he could have. I think his shoulder. What I mean, it's not a complex shoulder case. It's someone I think anyone could have seen too. But I think just keeping in mind some of these other management principles with it. Here's patient number two, and Brian, you're going to know this one, so you just get some extra info on this patient here. JT is a 67-year-old male with a 1 year history of an above knee amputation that our hospital system, oh, he was on the table for cardiac catheterization, and I believe an aortic balloon like collapsed, and he woke up from the table and his left leg had to be amputated. So very traumatic for him. He was new to my caseload. We had another physical therapist who had left, and so he was transferred, and he had been seen 39 times at that point by the time he came to me for prosthetic training. And at the same time, he was in pulmonary rehab 2 times a week. So, I'm asking him, I'm like, hey, so what is it like for you using your prosthetic at home? Like, what kind of things are you walking a lot? And he told me it's an expensive door stopper. Not using it at all. He's living life in his wheelchair after 39 physical therapy visits, after being in pulmonary rehab all this time. And he just told me that he had ongoing distal stump pain, point tenderness, hard mass on it. And he just said, like, I've been complaining about it all this time. No one seems to be listening to me. Nothing seems to be happening. But also at the same time, he was coming in with a blood pressure of somewhere between 80 to 90 over 40 to 50 at every single visit, too. And so this isn't part of this conversation, but this was another case of it took way too long for someone to get follow-up care and be directed into the right path. He ended up having an ablation, and his blood pressure and all of his other symptoms ended up normalizing there too. But his stump pain was the biggest limiting factor to his to his quality of life. He was living life in his wheelchair, and his wife had to push him around everywhere. So he went to the general surgeon, and the general surgeon ordered a right limb ABI, and then they said, okay, we'll ultrasound your remaining stump, and that was scheduled for 2 months out. And then his PCP at this time had just prescribed him gabapentin for what they considered phantom limb pain, too, that he had been on for 6 months. So I get him at this time, and I'm thinking, okay, let's give it the old physical therapy go. Let's be a outpatient PT here. So what did we do? Well, I knew that his aerobic activity and cardiopulmonary function had already been really challenged because he's going to pulmonary rehab 2 times a week with our exercise physiologist. So I'm like, great, you have that part covered. Let's work at some exposure therapy. Let's work at graded loading through the limb here. And I want you to start trying to utilize the prosthetic daily. He came back and he's like, oh my gosh, it's still really, really painful. Okay, so let's think about socket stabilizing. I reached out to his orthotist and was thinking about, okay, is there anything about the femoral component that we need to adjust to change pressure across the limb? Can we try and play around with different socks on it too to change the thickness? Maybe that will feel more comfortable and change up how you're feeling there too. We did hip strengthening, we did core strengthening. I gave it my best physical therapy try um, for a month, for 4 weeks, visit 1 time a week. And then I told him, because he kept complaining about that distal spot, and I said, okay, you know what? Let me just scan it myself. All right, let's just throw the probe on there. And this is what we saw. So here we're in a transverse view of the distal femur, and I'll dip it down. Immediately, you can see a nice outline of the femur here. And then you also see something that I think anyone, even if you don't do ultrasound, know, like, oh, something doesn't look right. There's a big old black mess that's just kind of sitting there, right? There's this big old collection of fluid at that point too. So I start scanning down, and we start seeing these white little, you can see these really focal hyperechoic kind of dots that are here too. And that's another case of things not looking too nice. And then we start going down further, we start seeing a very prominent osteophyte kind of bone sticking out exactly where he said it hurts exactly when it presses here every single dang time. So I start going, oh, that's pretty interesting. This is a long axis view of that too. So you can see that there's actually some sediment that is collected further down. That's why you see this darker area, and then you see this kind of anechoic lighter area at the bottom of the collection near this osteophyte here at the end too. Um, so I mean, I'm not an ultrasound technician. I'm not a radiologist, I'd say, but I think I know enough to know, okay, focal hyperechoic regions and these gas bubbles are not normal. In fact, it actually can be a sign of infection that needs to get managed and checked out. He's been having pain. This has been going on for 2 years focally, and he has pain replicated with sonopalpation to this point there too. So I take these images and I just send them directly to his general surgeon. And they, of course, they don't get back to me. I'm just a PT who wants to talk to a physical therapist, right? But I manage his chart, and the next day they order a stat ultrasound. So they move his ultrasound that was supposed to be scheduled 2 months out. They move it to the next day, and then they schedule him an emergency CT scan too. for all of this. So I see all of that workup going on. He comes back to me. I let him know some of the findings. And so I told him, I was like, hey, physical therapy is not for you. You've been at it for long enough. I think you can say that you have given everything that you have and that this is not working well. We got to get your team on your side here. We got to get the ball rolling. Um, I mentioned the surgeon ordered a new stat ultrasound exam, and the CT followed 2 weeks later. Actually, through the CT scan, they found that he had a 60% common iliac occlusion and a large fluid collection. The way that the technologist positioned him in the CT scanner also cut off a quarter of his amputated limb, so they couldn't. There was no slice to get to the bony prominence because they just didn't capture it in there too. The CT wasn't lateral enough to get it. He just came back to me last week saying that they are now moving him towards surgical planning, but because of how complex his case is, he has to consult with his pulmonologist. And then they're trying to find vascular surgeon to work with general surgery because they're going to try to clear his occlusions at the same time um, as well too. So a case where the PT intervention, the classic mindset, let's range of motion your hip. Let's see if biomechanically we can change the way pressure goes through your prosthesis. Let's try to manage your strength with an HEP. Let's do some balance training and desensitization training there too. Let's talk about your beliefs. Do you think that every time you're putting weight on the limb, tell me a little bit about your experiences with this. I know that was a really traumatic event. We set outcome goals for him. I tried to make them very person-centered to things that he wanted to get back to and wanted to do. And then I collaborated with the prosthetist on the adjustments. But the primary care management that I'm really glad that I had for my 2 years being embedded was taking ownership of the patient's goals and conditions within my scope of practice. Their PCP isn't the one who's going to be able to make timely decisions on it. Their general surgeon was. And so I work in a system where I can just send those things straight over to them. What did I write here? I wrote, who's the captain and who can do the work? Uh, Diagnostic ultrasound with education on his findings. As I went into it, my thought was, and I guess with any imaging, will the image change management too? If are we trained to recognize something that would change our management? Because it's one thing to just look at it and be like, oh, that's interesting, but do we know what to do with the information that we gather from there too? And then presenting treatment options, presenting a menu of them too. I told this patient that we could continue training. He wanted to because of the situation in which his amputation was caused. All of his care is paid for and free, and I think that's a reason why he stuck with PT for so long, even though he was getting no results for those early 39 visits, was because it was paid for and he didn't have to pay. He didn't have to do anything for it. He just showed up because they told him that's what he needed to do. Um, yeah, that that was that case. And so in in some conclusion here, I think reminding myself that I am a chain link in a very large healthcare chain and I am not siloed out. I am still a member of a team, even though I'm not embedded. I can work at building collaborative relationships and I can help to make sure that the patient knows that they're also not forgotten about in PT land either. Questioning and advocating at the edge of my scope. Again, I'm preaching to the choir here because a lot of us are doing things that most PTs I think would be a little gun shy about there too. But if we know what steps can be taken and should be taken, at least ringing things up the flag in that way and educating patients and other providers too, because the only way we're going to get our scope changed is if we can prove competency. And we can only prove competency by showing examples. And I think this is the group that's doing it too. And then finally, working to build collaborative networks with PCPs and other specialists. Again, it's a lot of it is driven by the organization and resources that you have on hand. I'm lucky enough to be in a spot where I can message people I can shoot emails out to specialists. They might not always refer or they might not always respond to me, but they see it and I'm glad they're doing something about it too. And with that, I'll end with this photo. I leave back to go to Hawaii to visit my family in like 3 days, and I'm so excited. So you can see these are my two nephews. That's Malachi and Makoa, and my muscular little brother over here on the side there too. But everyone, thank you very much for listening in, and I'm here for any questions.
Thank you so much, Micah. That was awesome. And I do know we have some students on here too. And so I think it's so cool that you got those experiences in primary care just like right off the bat, because that's such a unique like experience just to be able to like go into that and say like, hey, I did this. And now to like be at this like level of competence with like technically not a ton of experience, but to like then apply it and build and grow is so awesome. And I think there's definitely some people on here that are hoping to follow in your footsteps. And then I think you did a really good job of highlighting a couple of other things that overall I feel like are pitfalls of like the physical therapy education and the, like you said, the lone wolf of like we see ourselves of like you said, I want to hold on to the patient and like not let them go because it's my job to get them better. And I feel like especially with like students and new grads, like you're not setting yourself up for success if like that's your approach. And so I really like how you take the PT intervention and then the primary care management because balancing those dynamics could be so helpful and not just seeing it as like being an interventionalist because to be a good interventionalist we have to be a good manager too. So
Mhm.
really awesome points. Thank
Thanks.
you.
And I recognize too, I think like for example, um, OCS and residencies, I think do set PTs up pretty well in some of these critical thinking aspects here too. For me, I just didn't have the experience of being like a full-time outpatient therapist. And so I found that a lot of the skill sets that I had actually built in family medicine, primary care, didn't apply at all to outpatient care. So it was funny because I wasn't, for a while, I wasn't the guy you wanted to send your shoulders to for long-term rehab because I was so used to helping make critical decisions at the point of care for direction. And then doing like really focused education interventions with patients and trying to manage their expectations through those things too. So yeah, it's funny because the skill sets they're so helpful in some ways, and then in some ways they're like two separate jobs.
I got a question, Micah.
Hit me, Brian.
So you work in as an outpatient physical therapist in a hospital setting. Now, and you came from this like I'm just going to use a primary care collaboration, and then you're kind of describing, hey, maybe you took a step down from that inter or trained disciplinary interdisciplinary care down to where you're at in the outpatient setting. What about someone that like, for instance, works for a private outpatient physical therapy clinic that doesn't have access to I'm not sure, but doesn't have access to the charting information that you seem to use quite a bit in terms of making good decisions with with exactly what you presented on. And then, if a student or something is like, hey, I'm kind of deciding between where I want to go. Do I want to go to a private outpatient clinic or do I want to go for one of these hospital-based ones or, in a medical system where you might be having more access to like Epic or something like that? Maybe could you describe your process of doing a prep chart review for a patient? Just like maybe um, just a quick little lowdown, either one of those case examples, just like where's your head at? What are you thinking? Just for all of us that might be wanting to be more involved in this way.
Yeah, I'll, because there were two questions there. One of them was if like classic private outpatient clinic without Epic access, without, robust medical history built into the documentation. And then two was pre-charting what things to look for to prepare yourself in that way. Do I have that right?
Yeah.
Okay, okay. Um, it's funny because right before I went to Samaritan, I was in a therapeutic associates clinic, which in Oregon is a private practice, classic outpatient clinic there too. And it definitely is clunkier, but I felt like my CI did a good job of he just through networking would have a ton of the referral physicians' emails and some of their phone numbers for the ones that he had worked with consistently. So he was able to maintain communication that way, although it wasn't like a traditional model that could be documented. Like in Epic, I can leave a phone call note to document that I did try to reach out to someone's PCP. And then there's a paper trail of our communications back and forth there too. So I think the networking piece becomes more important. It's a lot more legwork, a whole lot more legwork. I think it's not easy, but I think that would have to probably be the case there. Um, and then two, on the pre-charting aspect of it, gosh, I'm so lucky. I'll make this super fast because it could be super long. I start with
Right.
what generated the referral. So like I just open up the referral note and see what generated that, like what encounter got to that referral. From there, the PCP or whoever there usually has like a little section on diagnoses or health history. And then I compare that with Epic Snapshot too, because sometimes there will be discrepancies between the two that don't get correlated with our EHR. So then that kind of gives me a fuller view of it then. I then try to scroll through for at least like I just scroll quickly through for the last 3 to 4 years to see emergency department visits as well. Because if it's someone who's chronically using the emergency department, I want to know like why is there a chronic health condition that they're feeling is not met? Like, is there a social determinant here in this too? Is there a lifestyle factor here with this as well? And then I will look through I can go through the search bar and then I can see the specialties there too. And so I'll be very interested in like any kind of like cancer, heme onc referrals that are there, any kind of like orthopedic referrals that are there too. So yeah, I start with the specific encounter. I look for ED visits and then I try to look through specialty notes that are there as well.
Thank you. And nice job too. I mean, you can tell the buck really stops with you with a lot of these patients, just even down to simple things like noticing that this amputee patient is already in doing pulmonary rehab. I think that's something that could easily be missed. And you could be like, okay, you know what? I could tell maybe you need this, and then they're working on it, and the patient might not say it. And it's just like
Uh-huh.
you're spinning your wheels. So just, I mean, obviously this shift in primary care stuff is like huge, like what you're doing from identifying ultimately like a potential infection in his amputated limb, but even something simple as realizing he already is doing another like pulmonary rehab, and then giving him exactly what he needs for what he's coming to see you for is just really, it's just really solid. It's just good care. So nice work.
Thanks, Brian. It's a lot coming from you, man. Thanks. Kyle, you're muted.
Sorry, thank you. Yeah, I have a question. A moment ago, you mentioned risk tolerance, and I was curious how your risk tolerance changed over that 2 year period that you were in the primary care setting, and also what role diagnostic ultrasound played in adjusting that or not.
Yeah, so when I was in the family medicine clinic, my risk tolerance was way higher because you were in a collaborative environment with physicians and attendings and residents and like a ton of different people. And so if I was unsure, I could just go talk with someone too, and we would feel better about all those things. So of course, my individual risk tolerance, I felt a little better with uncertainty because I had a feeling that someone else was going to be able to pick it up. When I jumped back into the outpatient clinic, I would say that my risk tolerance was too high because I was not in my collaborative networks. I didn't have immediate access to X-ray or lab ordering that I could just go and talk to one of the physicians for and get, because I can't order anything. It's still all through them. It was actually it was too much, I think, in my first couple months of being back in outpatient. So what I would say now is that I use my reviews and I use diagnostic ultrasound to improve my risk tolerance and to answer clinical questions. So I'm not just searching. Like for example, in this case, if it's an infectious like adventitious bursitis is what I ended up like diagnosing that as in my head. Adventitious bursitis, he could be perfectly fine, like low risk, but it's those hyperechoic foci in it that raise the suspicion for infection in someone who already has poor perfusion. and who already has a ton of comorbidities. So then the risk heightens in those cases too. So yeah, I would say that now that I've been back in it for the last like 2 years and just standard outpatient care, I'm building out my risk tolerance because I have better systems in place, and I think my knowledge, like your knowledge, just kind of increases the more that you see patients and your time in it too.
Hey, Micah, how's it going?
Hey,
Uh,
Micah.
I just gotta say, great information, great name. My question for you is, any plans to get a clinic started back up again where you're at?
There is talk about it actually. Funnily enough, what has more of a likelihood of happening is starting up our pediatric primary care program because there's just so much more of a need and there's like zero availability of pediatricians in the area. And our pediatric PTs are like swamped and overwhelmed. So there has to be some kind of like upstream management help with it. So that is something that's in the works with us. I don't know the timeline on it. It's probably on like a years long timeline, but it's actually something that's being talked about. Our program got shut down for reimbursement issues because insurers didn't know what to make about a PT credential being linked to a primary care note. Even though we were billing even though we were billing incident to, the insurers just had no idea what to do with it. And we had no institutional support to fight for us with those. So my manager, who's just the manager of like our outpatient department, was spending his like weekends and off hours making phone calls to insurance companies to try to do that. And that shouldn't be his job because he doesn't know that stuff. He's like, that's not his role or responsibility. So insurance got in our way and then institutional support dropped because hospitals across the nation saw reimbursement dropping and their margins got thinner. So their tolerance to taking on different projects dropped too. So that was a piece of it. There is interest again because we have a new CEO. So he heard about it and was like, "Oh, that sounds really cool." I'm kind of I don't know what's going to happen there. That's how I feel about that.
Gotcha. Sweet. Thank you.
I have another question if you want, but hey, you should go, Shannon.
Oh, thanks, Brian. So, yeah, I appreciate this is great information. So, I actually have a question kind of from the educational side of things. So, I teach, I did residency, OCS, all those things, and I agree that it really gives you that healthy lens and perspective.
Yeah.
Now on the academic side, I teach our differential diagnosis and diagnostic imaging class, which the more I learn and read it is basically I see it becoming a pre-primary care class. And so what I wonder about is kind of like you talked about those shifting lenses, is trying to reconcile the fact that like we very much emphasize you have to be looking out for is this a just you're good to treat, watch and refer, watch emergent referral, that type of thing, categorizing
Yeah.
patients using imaging, but that's in all settings, but then also with that primary care. So what I wonder is just kind of be curious to hear your thoughts on what your educational experience was and then suggestions on how you kind of reconcile those two elements. Because from talking to people, read a lot of things from Katie O'Brien, other people, just hearing these other experiences where
Yeah.
it's a very different mindset to be in that space where you are trying to triage. You're not trying to do that whole PT brain. I'm not trying to have a 45-minute session. What immediately needs to happen for this person? And maybe that is them going to PT. Maybe this is a referral, like you said, for imaging. But I'm just curious, kind of your thoughts on the educational focus and what you'd like to see in that regard.
Yeah. I graduated in 2021. And so the imaging standards for CAPT programs, I don't think it had been finalized at that point, but it had already been talked about and a ton of programs had rolled it out. So our program, George Fox, did have, we had 2 full months of like a really focused imaging course in class. Um, and then also we did have a few weekends of diagnostic ultrasound use too as part of my training. So I found that helpful, at least to get my foot in the door. Do I think it was enough for primary care and making decisions like that? No, I do not. That came because thankfully I was in a teaching program with residents in the family medicine clinic. And so I got to pepper them and I got to be, the new grad PT that didn't annoy people by asking them questions. And so I I don't know the answer to that question. I think about that. I think about that too. I started teaching with Western University of the Health Sciences here in Oregon as well. And I'm trying to think about like, okay, there's so much to learn. Like, how do you get some of these concepts? Like, because it takes a lot of time to do. So I do think that it almost needs to get married with orthopedic, like the orthopedics class, so that you can be seeing use cases for it and it's not just its own separate thing. Like it needs to be integrated maybe even into like anatomy. So like my Clarius scanner that I just bought now, my handheld probe, I've already taken third year students and I've taught every third year student who works with me comes out knowing how to use diagnostic ultrasound. But also I think imaging just needs to be worked into everything rather than being its own isolated class. And then maybe you can do specific classes on like in like interpretations of it. But I think if it gets integrated more, it will be more helpful than shunting it off to its own thing.
I think you make great points. So like for us, it's an evolution. Like the class differential diagnosis for us is pretty much they've already taken all of their didactic classes. They've taken everything. I teach in the ortho track, movement science, these other elements. And so now I'm going
Yeah.
back, I'm talking like, hey, we need to pull this in from semester one. So you're learning anatomy. Anatomy is a lot, but at the beginning of the program, can you just introduce some of the basics of interpreting, looking at x-rays, seeing these different perspectives and connecting? I think it can actually enhance
Yeah.
things, but without going too far into it. So yeah, I
Mhm.
mean, I appreciate that. Like, it's hard to get them to. There's people that go into these clinicals. If you're in one of these spaces, like a military space with the VA, where you're able to have a clinical and you're practicing, you can really hone and build on those skills. But for me, it's looking like once you're entry level, it's hard to get someone entry level to be proficient in all of those skills. But I think you could create a big foundation. So if they do go into that space, it's very, very easily for
Yeah.
them to kind of pick up. And what I've heard lastly from a lot of other people is you kind of develop these skills. I feel that our students are pretty strong in those areas. But then if you go into most ortho or other spaces, you're never actually going to build and use these things again. So
Yep.
this really strong base that you built up now kind of goes away. So yeah, it's just kind of reconciling those things. So I appreciate your insights on that.
No, Shannon, that's so right. Brian and I went to the same program at George Fox, and I don't know about Brian, but I felt that same frustration. Like, for example, we were taught a lot about diagnostic imaging, practicing at the top of our scope, and then I was in a family medicine primary care environment, and then it got taken away, and I went, okay, what was all this training for? What did I go through 2 years of this for? This skill set that I think I'm very specialized in, but I have no place for it unless I join the VA, like, or unless I join the military, something, or I go to Bellin, I can move up there with those guys. So yeah, no, I definitely understand that feeling.
Shannon, where are you at?
So I'm at the College of St. Mary in Omaha, Nebraska. We're a hybrid program. So
Okay.
incidentally, I'm actually we're trying to kind of work on integrating some of these things into with some of our local entities here on getting into this team-based primary care space because it is. I mean, I'm sure we could talk. It's kind of the future of things. Like there's a shortage of people in the primary care space, but I talk to people in different places. Literally, one of my friends, he's finishing his fellowship. He just took a job somewhere where he's being asked to kind of create one of these models in this space. But there's the same
Cool.
things. You got to have buy-in from somebody. How do you work out reimbursement? And it doesn't seem like there's a consistent blueprint for that because it's so variable from place to place.
Yeah. Yeah. Like us, we tried the insurance route. Bellin, they're just on value alone. Like the physicians just won't let them go. The physicians just love them so much. We tried that route and the CEO went, ha, great, doesn't pay the bills. You love them, but can't bring them back.
I was gonna ask my last question was just any time management tips and tricks you might have because I mean if you can't be on hold all the time with the PCP or whoever you're going talking to. I mean you got any tricks?
Well, the funny thing is that so I tried to think through recent examples for these patient cases. So these are all in the last 1 to 2 months, and I've had a student for the last 1 to 2 months. So having a great student is a good tip and trick there, so that they can see patients while I'm doing these things here too. Yeah, the Teams chat. I mean, the Teams chat was awesome. Emailing so that you don't have to be waiting on hold there too. But like with the one guy for his for changing through his ibuprofen to like a Celebrex or PPI, and I was on hold for a while before the receptionist picked up there too. So yeah,
Is chat within your system, or if I was on Epic, could I chat with someone else, or is that
It's
too
within
separate?
system.
Yeah, that's what I figured.
Yeah,
Okay.
Brian, I just be instant messaging you all day, man.
Man, yeah, that'd be fun.
You can send emojis through there too.
Oh, really? Perfect.
Cool. So I'll let that round us out for tonight. Awesome questions, everyone. And again, thank you so much, Micah, for not only sharing your experiences, but your cases. And I just think that there's like so many awesome takeaways for any kind of provider to take that and go apply that to their own practice or really just get some ideas on how to like move forward in the future. So thank you so much for sharing that. That is our community of practice call, sort of like what our standard like presentation sort of looks like. Currently our next one's scheduled for January. And we'll be sending all of that out when we get the final details of that. I try to put it on our social media accounts on Instagram and Facebook for the primary care SIG. LinkedIn. And then if you're on the SIG, you should get like the emails for that too. But if you're at the beginning, we're still sort of working out some communication. So feel free to reach out to me if you have any questions, Evan or David, who were on here. They are all part of our board and would be happy to just get everyone involved, answer any questions in the future. So thank you so much for attending.
Thanks for hosting, Lane. Bye, everyone.
Thanks, Micah. Great job.
I'll see you in New Hampshire, Evan.
Yeah, see you at Christmas.
Bye.
Bye.